Good morning, everybody. Thanks for coming. Welcome to the Pediatric Grand Rounds Surgery section, I guess is what we'll call it. We have had a little break, and unfortunately we've got 2 months of breaks after this because next month is Quality Day, and then the first week in July is the 4th of July, so we won't have a surgery Grand Rounds until August. And that Grand Rounds will be Dr. Karamalud talking about congenital heart surgery and population management and transparency. So, but today we're here to hear from Dr. Notrica, who really, I don't really need to be standing up here to introduce him. You guys all know him. He's been here for forever and has done a yeoman's job of running the trauma program, which we should be incredibly proud of. What he did about 6 years ago, maybe now, I guess, is that he took on the task of answering a question that had been spattered across the research arena about the best way to address solid organ injury. And there had been several studies that have been done from single institutions, but what Dave did was he got initially 6, I think that's right, is that right, Dave? 6 institutions to buy on to treat solid organ injury the exact same way, which anybody in the room that deals with surgeons, getting surgeons to do anything exactly the same way is almost impossible. But he got 6 institutions to buy on, and by the time they finished the study, they had 10 institutions. So it just, I bring that up to drive home the point about how important this project was for pediatric surgery and for pediatric care, but more importantly, just to give Dave the kudos he deserves to accomplish something on that magnitude across 10 different pediatric hospitals and departments of surgery and departments of medicine in emergency medicine. That has led to a windfall of publications and presentations and surgery residents that Dave's now been mentoring, and we really owe him a debt of gratitude to put Phoenix Children's Hospital on the map with regard to trauma, which I would say across the country now are perceived as one of the major players in trauma surgery. So with that, I'm going to turn the podium over to Dave, and he's going to talk about abdominal trauma and the error evidence.
All right, I should be good. I warmed up this morning by doing a gastroschisis at 2:30 in the morning, and so I've got my monster beverage to get me through. As you can tell from the handouts, it's a dense talk, and it was a dense paper. I'm going to start by telling you a little story about a patient, a 17-year-old male, and he was involved in a motor vehicle collision, and these are photos from the actual crash, and he was in the front seat, passenger side, and his car was T-boned on that side. It took about 20 minutes to get him out. He was moaning on the scene. He had a Glasgow Coma scale of about 8. They intubated him in the field, and then he was transported to Phoenix Children's Hospital. In the ambulance, they did have some airway problems. They did finally extubate him en route because they didn't feel like they had him intubated correctly, and then they brought him to us. So upon arrival, he was getting bag mask ventilated. We intubated him immediately. His chest sounds were asymmetrical, so he had diminished to absent breath sounds on the right. He had massive crepitus in the right chest, and his sats were 83%. Heart rate was 120, blood pressure was 74/50. He was pale, cold, had weak central pulses, and delayed cap refill. And so what do you do next? Well, airway, breathing, circulation, he's intubated and B is breathing, and so he gets chest tubes placed, and he gets bilateral chest tubes placed because he's hypotensive. And we get about 600 milliliters of blood that literally gushes out of the right chest under pressure, and gets some air. We capture about 300 mils of that in an auto transfusion setup, and his sats come up to 90. But his blood pressure is still 70/30, and his heart rate is still 130. That gives him a shock index of 1.7. Now, for those of you who aren't familiar with the shock index, it's a pretty simple number. It's the systolic, it's the heart rate divided by the systolic blood pressure, and normal should be less than 0.9. And once you get higher, the greater the chance that you're going to need an intervention or that you're clinically in shock. He was still pale. His abdomen was distended. He had no obvious deformities. His chest X-ray looks like this. I will point out to you that he's got a lot of subcutaneous emphysema on this side. The chest tube's in place. We did not take a chest x-ray prior to doing this film because clinically he had a tension pneumothorax and he needed that chest tube. He's got another chest tube on the other side. There's a little bit of air on this side. His pelvis appears to be relatively intact. Don't see a pelvic fracture there. So he got transfused 2 units of packed cells and 1 of fresh frozen plasma, and his blood pressure is still 70/30. So he's not responding. So at this point, we activate the massive transfusion protocol, and we give him back 300 mils of whole blood from the chest tube, and do a FAST exam. And his FAST is positive. So a FAST is a focused ultrasound, just looking for blood. This is the liver here. This is the kidney here, and there's a bunch of black stuff in between, and that's blood. He's got a continuous air leak from the right chest. And as a thanks to all of this blood that we've given him, he drops his blood pressure to 50. So what now? He's got a head injury because his Glasgow is low. He's got a lung injury. We've got no CT scan. He's received 40 mils per kilogram of blood products, and his systolic blood pressure is 50 down from 70. So do we do an ED thoracotomy? Do we stay in play, do more lines, give him blood? Do we go to the PICU? Do we go straight to the OR? Do we go to the OR via CT scan? The CT scan is only 40 feet away. Do we do a REBOA, do a resuscitative occlusion of the aorta? We'll get back to that. So the Atomic Guideline really was designed to start answering some of the questions that patients like this propose. And I did not do this alone. When we started the guideline, it was a difficult process because we were taking some ideas and formulating them into something that we could make work. And these are the people that helped me with that process. But to understand what we did, you need to go back and understand the history. And so there was a time before CT scanning when if you had a splenic injury, you got a laparotomy and you had your spleen taken out. And in the 1970s, the Hospital for Sick Kids in Toronto, they began suggesting that maybe you don't have to operate on every spleen that's injured. That idea caught on, but it caught on slowly. And by the late 90s, most pediatric centers were doing non-operative management, and most adult centers were not. And so the American Pediatric Surgery Association Trauma Committee developed some management guidelines to help standardize care. And they recommended a length of stay that was based on the CT injury grade. And so the amount of time that you had to be on bed rest was equal to your grade of injury +1 in days. And generally that meant that you were in the hospital for the grade of injury +2 in days, because you're on bed rest for a day and then generally it took an extra day to get out of the hospital. They recommended ICU for grade 4 or higher injuries, and that the children were kept activity restricted for injury grade +2 in weeks. So a grade 3 splenic injury would have an activity restriction for 5 weeks. Within a few years, it was clear to pediatric surgeons that the recommendations that they had made initially were too conservative, and it resulted in excessive hospitalization. Simultaneously, the adult trauma centers and a lot of places throughout the country weren't hitting the benchmarks for non-operative management. They set a benchmark of 5% or less surgery, so a 95% non-operative management rate, and places weren't hitting it. Arkansas, in Sam Smith and his residents who are now attendings, questioned the appropriateness of using CT grade to guide management. And they wrote a paper that was called Throwing Out the Grade Book. And this was their second paper because their first paper was completely ignored. And what they said was, this is crazy. You need to manage the patients based on their hemodynamic status, not based on the imaging studies. And this paper, the second one, really kind of hit home for those of us who are pediatric surgeons doing trauma and saying this is not what we need to do. Their paper was pretty simple because it's Arkansas. And, and they divided the groups up into stable patients and unstable patients. My apologies to Lisa. Yeah. And stable patients, basically, if their hematocrit was less than 21, or hemoglobin was less than 7, they got transfused, and if it was greater than that, they just got stuck on the ward and sent home the next day. And if they were unstable, then they got 40 mils per kilo of crystalloid and 10 to 20 per kilo of packed cells, and if they got no response, they went to the OR. They just failed. If they did respond, then they got admitted to the PICU, and their algorithm looked kind of like it did before on the stable pathway, and this was it. And we thought, great, we can just compare the two. And I got together with my good friends at a research consortium that we had just started called Atomic, and that stands for Arizona, Texas, Oklahoma, Memphis, Arkansas Consortium. In Memphis is in Tennessee, but we didn't need an extra T. We already had one. So, so they became Memphis. And what we came up with was this, and this is complicated. It's in the publication that you have. But basically, this is the stable side, and this is the unstable side, and it just got a little bit more complicated. In the process of doing this, we all adapted this guideline, and at some point we said, you know, we've done a lot of work to make this guideline. We should publish it. And we went to the Journal of Trauma editor and said, hey, would you be interested in taking a publication that's a management guideline, is supported by experts? And he says, well, maybe. We sent it to him. He sent it back to us and said, look, you're probably onto something here, but we want you to redo this using GRADE. I'm like, awesome, what's GRADE? And GRADE, at the time, if I had known, I probably would have said, never mind. But GRADE is grading of recommendations, assessment, development, and evaluations. How many people here have heard of GRADE before? How many people have written a paper using GRADE? Yeah, you only do it once. GRADE was the brainchild of Gordon, evidence-based medicine, Guyette, and Holger Schunemann at McMaster University, and they started GRADE in 2000. Gordon is an internist in Canada, and in his quest for evidence-based medicine, really developed this into something that got published in a 20-part series in the Journal of Clinical Epidemiology. And GRADE is an approach to making judgments about the quality of available evidence and the strength of the recommendations. This is a partial list of some of the institutions that are using it. The Cochrane Collaboration, the World Health Organization, the CDC, BMJ journals, up to date. Yeah, I mean, wow, that's when up to date starts using it. I think it really ups their game in so many ways. The way it works is this: you start with an informal question, and then you turn it into a formal question. The formal question is in PICO format, and PICO means patient population, so you define the population. I, as the intervention, you clearly define the intervention that you're looking at. You're going to clearly define the comparators and the outcomes. And we basically took the algorithm, every decision point, the instructions for use, and the discharge instructions, and we generated informal questions. There are 27 informal questions. We can't do all of them. We couldn't even publish all 27 of them in the journal because of the word limits. And they said you can publish it as a supplement, which we did. So after you've got your PICO question, then there are two other things you have to do. And you have to assign a grade to the overall body of research. Now keep in mind, what we used to do is we used to look at a paper and we'd grade the paper, and we'd give that a grade. And that doesn't make sense. What makes sense is looking at the whole body of information that surrounds a question, grade that body of evidence as A, very confident, or D, little confidence, and the confidence really has to do with the quality of the trial designs, the magnitude of the effect, the number of publications that have collaborated that effect. And it's important that you also look at the outcome measures, and that you determine your outcome measures before you start as what's really critical and what's important and what's of limited importance. And then after you've done that and you've kind of assessed the body of evidence that's available, then you give a recommendation as a strong recommendation or a weak or conditional recommendation, and that's a 1 or a 2. So The algorithm gave rise to 27 clinical questions. We queried Medline using search terms that we thought were reasonable. We excluded publications prior to the APSA guidelines, so everything prior to 2000 was excluded. We threw out everything that didn't address management of blunt splenic injuries, and we added additional studies as we needed in order to answer the questions. We came up with almost 600 articles. 388 were excluded because they were old, and another 240 were tangential, and that gave us 142 core articles to make the decisions on. These 142 articles represented 69,000 patients. And the type of literature that these patients showed up in is shown in the graph here. And what you see is about half the patients show up in retrospective studies. About 2/3 of the research is really case reports or case series. And then the database studies, even though it's 12% of the published research, accounted for about 45,000 of the patients that was used to garner the information. And then there's kind of a breakdown of the other stuff, literature reviews, opinions, prospective studies, which was only 4%, and meta-analyses. These were our important outcomes. We defined them as critically important, important or limited importance, and those are in there as well, so I won't dwell on that. There's our original algorithm and our informal questions, and the first one was, should management be based on CT scan or hemodynamic status? Makes sense. You put that in a PICO format and it becomes, in children with blunt liver or spleen injury, is there adequate evidence to support non-operative management based on hemodynamic status rather than grade? And we truncated that because really you should have the outcome, which is in order to improve non-operative management and save lives. But these get really thick very quickly. What we found is that there were 4 prospective studies that were available for review. They had more than 500 patients enrolled. There was adequate follow-up in those studies, and it was also supported by an adult guideline, and there was historical support, because before we had the APSA guidelines, that's what we were doing. We were taking patients who were unstable and operating on them, and patients who were stable we weren't operating on. And so that got a 1A recommendation, a very confident recommendation, strongly recommended. And so you start the algorithm, the first thing you have to decide is, are they stable or unstable? No problem, right? Well, that question is, can hemodynamic stability be defined, or is clinical determination of recent or ongoing bleeding necessary to determine management? We knew that this was going to be a problem because the Western Trauma Association had tried to do this, and they had problems with defining what stable was. And it's worse in kids because children with head injury can be hypotensive without bleeding, and that's the problem. Or you could be hypotensive because you're bleeding from your pelvic injury or other concurrent injuries that contribute to it. And there are even 2 articles that say that children who are bleeding may not be hypotensive. And so you've got problems in both directions. You've got hypotensive patients who aren't bleeding and bleeding patients who are not hypotensive. So the recommendation was 2C, and that's clinical determination has to be made of whether or not they have ongoing bleeding. All right. You saw a discrepancy between our algorithm and Arkansas's. They gave 40 per kilo of blood and we only gave 20. And so the question is, should crystalloid volume be limited to 20 per kilo before you transfuse? ATLS actually recommends 3 boluses of normal saline prior to transfusion. That's 60 per kilo. That's a lot. So we found 6 articles that were in human as well as animal models, and there was a large amount of evidence to suggest that giving big volumes of crystalloid, saline, or lactated ringers was detrimental to bleeding trauma patients. There was one article in pediatric patients suggesting that they were resistant to some of the detrimental effects, but not all of the detrimental effects, and they still had adverse consequences from excess crystalloid. There were no properly controlled studies available to answer this question. And so the recommendation came out as a 2C recommendation that we limit crystalloid infusion and that we transfuse early, and that's based on the adult literature as well as the studies that we mentioned before. How do we resuscitate patients? So we've decided that they're going to need some blood. Do we give them a 1-to-1-to-1 ratio of packed cells to fresh frozen plasma to platelets, or do we use thromboblastinography, TEG, or ROTEM in order to determine what they need? And the PICO question basically compares TEG, evidence for TEG, evidence to one-to-one, and evidence for clinical signs of coagulopathy. Unfortunately, you go to hit the literature on this, and the data is really limited. There was only one paper that even attempted to predict which patients need a massive transfusion. In the adult patients, one-to-one-to-one was felt to be useful, as was thromboelastography, but there was no data in pediatric patients. So there was no good data. So there was also a prospective study in adults that showed that while the retrospective data was good in adults, the prospective studies couldn't show a difference. And then later, there were 2 more adult studies that couldn't show a difference. In the peds patient, there was 1 retrospective study, and it was 105 massively transfused patients, and they showed no relationship between component ratios and survival. In a bigger study, 22-center database, so again, we were kind of dipping into lower quality data. They did show improved survival for both high plasma and high platelet to red cell ratio. So if you give FFP with your red cells, you're more likely to survive. And so the recommendation came out as what would have been a 2B recommendation because there's a reasonable amount of data, but it was downgraded to a 2C recommendation because of publication bias. And so the recommendation is to consider the use of one-to-one-to-one transfusion early. And then the other question, which was the TEG-directed therapy, was felt to be useful, so it got a 2D recommendation, which is expert opinion only, because there just wasn't data out there. So, should we be giving transfusion in order to try and improve non-operative management? I mean, it makes sense in a lot of ways that these patients are hypertensive and they're going to give blood, but if you give them blood early, can you actually save their spleen? Can you save their liver? And we know that many patients are taken to the operating room prior to ever getting a blood transfusion. And additionally, if you look at the patients who are successfully non-operatively managed, about 18% of those patients are transfused. So we did the literature search on this, and there's no direct data of timing of transfusion and non-operative management success. And there's also no data found to support that surgery prior to transfusion improved outcomes in any way, even saving less blood. There's just no data out there. And a strategy like this in adults clearly is going to result in a higher rate of operative management. So combine that with the concept of permissive hypotension, so letting them stay hypotensive instead of tanking them all the way up and getting their blood pressure to normal. It showed promise in animal labs. It showed promise in the adult trauma literature, and ATLS actually now includes permissive hypotension as a recommendation for children without head injury. And so you can only, in this format, you can make a recommendation, but you can only back it up with data that's out there. And so this came out as a 2D recommendation to consider transfusion of red cells in response to shock prior to surgery, but no evidence supports an improvement of non-operative management if you do it. Can an algorithm even determine who needs to go to the OR? Well, that comes out as in children who fail to initially stabilize. Can management be done through a single arm of a practice management guideline algorithm, or does treatment need to be individualized based on concomitant injuries and local resources? So we talked about earlier that pediatric hypotension is often not due to bleeding, and it's difficult to quantitate the relative contributions of the different injuries. And so an operation for failure to stabilize is kind of a basic tenet. It was in the previous studies. It's kind of the way that we manage them. And so if you don't stabilize, there's not much that you can do. Hypotension due to solid organ injury is ominous, and patients with hypotension due to solid organ injury are at much greater risk of death. So we've got a real problem here, because if we're wrong, we're really going to mess things up. In an adolescent study, they found that you can save some of these patients' spleens by embolizing them, and that data was starting to show up in the literature in a pretty strong way, saying that maybe instead of operating them, taking them to the OR, you should take them to the cath lab. At the end of the day, you've got multiple studies that say that if they fail to stabilize, you need to do something. But what that something is has to be based on local resources. And instability does not necessarily mean bleeding in the trauma patient, and so you've got to use clinical judgment. So what that led to is that the algorithm gives you a failure for the algorithm, but not necessarily a failure for non-operative management. And that's really important. We'll talk about that a little bit later. So very confident recommendation. Failure to stabilize, as noted by persistent and then later recurrent hypotension, cannot have their management dictated by an algorithm alone. And so you get to this point where you've failed the algorithm, and then the surgeon has to decide, are you going to go to angio, are you going to go to surgery, or are you going to continue non-operative management? When we submitted this to the journal, we got feedback and pushback from every one of the reviewers on this. And they basically said, no, you got to go to the OR. Got to go to the OR. And we said, look, that's not what the literature says. And finally, the editor said, yeah, you're right, that's not what the literature says. And they ignored the reviewers and published the paper as written, and the algorithm as written. So a patient can potentially reach that endpoint and not fail non-operative management. Is there even a role for angiography in these patients? And that's a big question, and it's a tough question. And so we broke it down into, is there evidence to say that it can be performed with minimal complications and that it's effective, and so it reduces bleeding or the need for transfusion or allows splenic preservation when using non-operative management? Well, it's been recommended as an alternative to splenectomy in the adult centers, and there have been 11 articles, including case reports and small series, that describe angioembolization as successful and safe. And there's a few studies that show that children with contrast extravasation, which is kind of the indication for being embolized, that even if you have bleeding, so contrast leaking out of a splenic vessel, that they don't need angioembolization. And so the data is very conflicting on this. So what you have is literature showing that very few of the patients need angiography, and only half of those that need angiography will get embolized, and that the number of patients that you need to treat with a prophylactic embolization is 37. So you would have to embolize 37 patients who would get no benefit from it in order to actually have a meaningful effect. This is a fairly typical article that reviewed 1,000 patients. 3% had angio, and 11 of them got embolized, and a third of those of that 11 ended up going to surgery anyway. So it's tough to look at this data and say, wow, we should recommend this. By the same token, if you're one of these 8 patients who avoided a laparotomy because you got embolized, then it probably was worthwhile. So really tough. As far as complications go, the complication rate from angioembolization is not that high. It's about 7%. There are 3 major complications in that series that I just showed you, and not all of them can be directly related to the angioembolization, but we think that the incidence is low. And so the recommendation came out was that it appears to be safe, and in a select group of high-grade injuries that continue to bleed, it may have a role. And then in the late phase, in grade 4 injuries, the patients who do well and then start getting pain or symptoms, you can embolize those patients late. So 2C recommendation, angioembolization may improve splenic salvage and possibly complement available treatments. And most children with contrast extravasation, however, do not require angioembolization. So what about ERCP? I threw this one in because we did the ERCP study, and so it was kind of cool to include it. There were 7 patients that looked at whether or not ERCP helped to avoid operation. They were predominantly case reports. Ours was a case series. And yeah, it's useful as an adjunct, often in conjunction with percutaneous drainage or lap drainage. And it's got a 2D recommendation, so kind of the lowest level recommendation of, yeah, you can consider it. So what about ICU admission? And you can remember that the ABSA guidelines said if you have a grade 4 injury, you go to the ICU. And if you have something less than a grade 4, then you don't need ICU. And there was good data, retrospective studies looking at greater than 200 patients, And admission to the ICU based on grade results in an excess use of the ICU. So you don't need to be in the unit just because you have a grade 4 injury. If you're hemodynamically stable, your management can be safely guided by the hemodynamic status. And we were really happy with that until we found out a couple of papers showing that grade 5 injuries are more likely to fail, and that grade 5 injuries are strongly associated with non-operative management failure, independent of hemodynamic status. And so the truth is the Venn diagram from grade 4s that are stable is really thin. I've probably overdrawn it here. But for the most part, hemodynamic status can determine the need for ICU admission. And with the exception of grade 5 injuries need to be put in the unit. Well, we talked earlier about transfusion thresholds. We really wanted to know, can you define a transfusion threshold? How much blood do you need to give these patients back? Normal hemoglobin is great, but the reality is, do we really have to tank them all the way back up to normal? Well, there are more than 9 pediatric studies that show that a transfusion threshold of 7.0 grams per deciliter in critically ill patients is as good as 9.5, and most of these studies include medically ill, non-hemorrhaging patients. They didn't focus on traumatic injury, but there was one randomized trial on post-surgical patients, and they found that a threshold of 7 did not adversely affect outcomes. And so 7 is probably a pretty good number. There are 3 prospective trauma studies that use 7 or hematocrit of 21, and we felt really good that the information was robust. It was broad from a lot of institutions, and it got a 1A recommendation that transfusion threshold of 7 is reasonable for children undergoing non-operative management for liver and spleen injury. Bed rest. Wow. Bed rest has been part of the treatment, the defining portion of treatment for non-operative management for decades. And so if you need, and we were going to basically try and determine how long you need bed rest for, but one of the authors said, hey, do you need bed rest at all? And we're like, wow, I never thought about that question. And so we basically said, all right, if you need bed rest, is there evidence for it, and if so, how long? Well, there's no evidence whatsoever to support bed rest as treatment for solid organ injury. And one adult study actually showed no effect. They let their adult patients walk around, and they did just as well as the ones that were on bed rest. For the renal study, which we participated in with one of the other co-authors, Sean St. Peter in Kansas, bed rest was completely unnecessary. There are 5 prospective studies that show that if you're going to use bed rest, you don't need it for very long, less than 24 hours. And so the assessment is that we had a good body of literature for an abbreviated period of bed rest, complete lack of evidence to support use of bed rest. But since every one of the studies included it in their treatment, it was hard to basically say, all right, we're just going to throw it out. And so it came out as a 1-day recommendation for an abbreviated period of 1 day or less, and that bed rest will be in continued recommendation until we have data to say it's not. My personal bias is it doesn't make any difference. I bet that this is going to get tossed out when we have better data. All right, so if they don't need bed rest, can they just go home? And that turned into this PICO question, which you can read there, but basically it's comparing our guideline to the APSA guideline. And we know that recurrent bleeding after an initial period of being stable is very uncommon. And so there are 5 prospective studies that demonstrated safety of early discharge. There were rare cases of delayed bleeding, patients basically who stopped and then bled again, but none of those bleeds that occurred happened during the grade +1 length of stay that would have been expected. So even though we're working hard to try and not let patients go home and bleed, those that do bleed aren't in the hospital when it happens. So the vast majority of patients who are going to bleed need intervention within 12 hours, and this would include patients that had contrast blast on CT, lot of studies. We looked at one patient that just, retrospective, one paper that just looked at failure patients. They had 1,800 patients. Median time to operation was 3 hours, and 87% failed by 24 hours. And only 0.6% of patients failed after 24 hours, so less than 1%. And another series said that the incidence of delayed splenic bleeding is less than 1 in 300. We're going to have a paper coming out about that later, but basically it's even less than this. So we can identify factors that put these patients at higher risk, and that's contrast bloodstone CT, bicycle handlebar injuries, and if they have more than one organ injured. Those patients are at higher risk of bleeding and probably should be managed differently. For the rest of them, good data to suggest that if they stop bleeding, that they'll be fine to go home. So this ended up in a 1A recommendation. Discharge prior to 24 hours appears to be safe. The exceptions include what we talked about before. Since they do have delayed splenic bleed, we came up with very specific discharge instructions for what they need to look for, and we basically made standardized education part of the algorithm, because if we're going to send them home, they need to know what to look for so they get back to the hospital if they are that rare patient who starts bleeding again. So, can we define failure? So, when do we know that this algorithm is no longer useful? And you'd think that this would be an easy question. When I was in training, I had heard that 40 per kilo was a failure point, and when I started looking for the literature, there wasn't any. And finally, somebody actually just did a survey of pediatric surgeons. They said, how much blood do you think you'd let a kid lose before you said we need to operate on him? And that survey data said was 40 per kilo. That was the point at which 50% of pediatric surgeons say, all right, well, that's my threshold. If I've had to give them more than 40 per kilo of blood, I'm going to operate on them. We also did a reanalysis of 2 other studies because there was enough data in there to look at it to see what the cut point was. And 40 mils per kilo really shows a break point at which surgery is probable. And finally, as we were, between the time that we wrote the first draft and the time that we wrote the second draft, a military study came out in children, and they basically determined that if you lose more than 40, if you give patients more than 40 mils per kilo of all blood products within 24 hours, those children were at increased risk of death. And so the first real data we had came just as we were getting ready to give up on this. So a moderate amount of data. There were no prospective studies, and the threshold really was predominantly defined by expert opinion and a little bit of data, and then we got it into the algorithm, and then our study, the Atomic study, changed all this, and we'll talk about that more in just a minute. So if you get more than 40 mils per kilo of blood products, you have failed the ability of an algorithm to guide therapy, and you have to use clinical judgment, and that has to be individualized. This paper concluded with 6 1A recommendations, 2 1B recommendations, 1 2B recommendation, 8 2C recs, and 10 2D recs. And we really, looking at the graph, we felt that we had generated enough good quality data to change the way that the children with blunt splenic injury are managed in the United States. The impact of this was defined by Dr. Dan Osley. He wrote this really nice paper that looked at what would happen if you saved, if you abbreviated the period of bed rest. And they estimated in theirs that they would save about 9,000 hospital days per year nationally. And if you do the math on that, conservatively at $2,000 a day, that's about $18 million a year. And that's every single year. And that's a lot of money saved. And the potential benefit is striking. But you need to prospectively validate this guideline. And so after doing all of this work, which we published in 2015, we had already, by that point, we had already started a prospective study. We did a 3-year study with 10 centers, as Dr. Osley alluded to validate the guideline. And our purpose was simple. We want to prove that it's safe, that the guideline has the ability to guide therapy, and that we can decrease hospital length of stay versus the current recommendations. We got IRB approval at all 10 centers. These are the hospitals that agreed to come on board. We did the study from April 2013 to January of 2016. We looked at algorithm adherence on both the stable arm and the unstable arm. We defined what were minor variations and what were critical variations. We looked to see how many patients got to the endpoint of the algorithm and how many of those had successful non-operative management anyway. We enrolled 1,000 patients, and this was, at the time, was the largest study ever done by threefold. And the median age was 10 years old. Most of them were motor vehicle collisions with falls and pedestrians being struck, accounting for a large portion of the remainder. Liver injuries were more common than spleen injuries, but about 10% of patients had injuries to both. This is what happened. This is how people got assigned to the algorithm. So the stable pathway was about 72% of the patients, and a larger portion of liver patients in the splenic, in the stable pathway. 8 patients crossed over. They were initially assigned to stable and then went over into the unstable pathway. We'll talk about those patients in a minute. 2% of patients developed peritonitis and therefore crossed over as well. And successful non-operative management based on intent to treat was 98%. In the unstable pathway, you'll see here that you've got a slightly higher percentage of splenic injuries than liver injuries. Those patients with both is about 22%. In this portion, 27% of the unstable patients reached the failure endpoint, and non-operative management was successful in about 81% of those patients who were initially considered to be unstable or bleeding at the time of admission. Algorithm adherence wasn't great, and we knew that this was going to be an issue, and that's why we divided up a priori into significant variances and less significant variances. And so 574 of the patients in the stable pathway didn't follow the guideline perfectly. And the things that they did were they got a regular diet, so 1/3 of the patients got fed, and about 1/3 of the patients did not get a type in screen. About 1/3 of the patients didn't get hemoglobin checks, and 20% of them were admitted to the PICU even though they didn't have to be. But there were no safety-related deviations, so from a safety standpoint, the algorithm worked. In the unstable pathway, about 29 or 10% of the patients followed the algorithm, and 90% didn't. And the variations including transfusion, transfusing patients who didn't hit the threshold, the patients who were in the PICU, patients that didn't have their hemoglobins checked, and 4% of patients who were in the ICU for potential bleeding and didn't even get a type in screen. Safety-related issues, about 40% exceeded the recommended volumes of crystalloid. About 22% of patients should have been admitted to the PICU that weren't, and 3% went to the PICU for their injury who didn't need to be, and basically 2% were not given blood, so basically their hemoglobin was allowed to drift below 7 without being transfused. The crossover patients are the ones that are most dangerous, that you worry the most about, patients who are misassigned. And of those 8, when you look at why they crossed over, the most common reason is that they needed more blood than was allowed in the stable pathway. There was one patient who got pretty sick, got hypotensive, and it was actually secondary to their pancreatic injury, not secondary to their liver or spleen injury. And there was one patient who developed respiratory distress, and that patient had a pneumothorax as the cause. So you're not seeing a lot of crossover for the actual liver or spleen injury. What about over-triage? Are we overusing the ICU for some of these patients? Well, we defined a population who were in the ICU for less than 24 hours, didn't get transfused, and didn't fail. And what we found is that there was a moderate amount of over-triage, especially in the grade 3 and grade 4 patients who were admitted to the unit didn't really need to be. 91 patients of those 1,000 reached the algorithm endpoint. And the breakdown of those 92 patients is that 62 of them went to surgery, 19 of them went to angioembolization, and 10 of them were opted to have continued non-operative management. Of those 19 that got embolized, 7 of them, of those embolizations did not prevent surgery. And 12 of them, it was successful. And so of the patients who reached the algorithm endpoint, 69 of 91 needed surgery, and 22 of those basically had continued non-operative management. So that's pretty good numbers of discriminating who should be in which group. The length of stay for those patients, the 979 patients who did not die, was about 5,600 days, and so the mean length of stay was 5.7 days, which is pretty long, especially if you consider grade plus 2 as the APSA guideline. But most of these patients who had longer hospitalizations were not hospitalized long-term for their spleen or liver injury. It was because of concomitant injuries. And so when we looked at those patients just with isolated injuries, what we found is that the total number of days in the hospital for those patients, that was 327, was 678 days. And APSA would have had those patients in the hospital for 1,200 days. And so in isolated injuries, you save a ton of hospitalizations just by using the abbreviated period of bed rest. Not everything about this algorithm was perfect. And about 8 months into the study, we had one patient who fell from a height of 60 feet. And they were climbing. They stabilized after transfusion and then went to CT scan. And in the CT scanner, they were found to have a liver, spleen, liver injury, splenic injury, pelvic fracture, traumatic brain injury, pulmonary contusion, tib-fib fracture, an T12 to L2 compression fractures, and active extravasation into the pelvis. That patient became hypotensive in the CT scanner. They had not received blood prior and went to the PICU. And in the PICU, got 8 units of packed cells, 4 of plasma, and some platelets. They ended up failing non-operative management and went to the OR for a splenectomy and died of bleeding. And what we learned from that, well, the takeaway from that is that recurrent hypotension is very bad. And those patients who and I'm sorry, I misspoke because they did receive blood before CT. Those patients who get blood and then get hypotensive after that, they're in a bad way. And so we modified the algorithm to make recurrent hypotension or lack of a sustained response a failure point for the algorithm. These other things we looked at, a lot of people were not getting typed and screened, and they probably don't need to be, because the number of patients in the stable pathway who the algorithm required them to be screened never needed blood, whereas in the unstable patients, a good portion of those patients were transfused, and probably worthwhile to cross-match those. If you try and look at it by grade to figure out, well, maybe the low-grade injuries need it and the high-grade don't, that didn't work out at all. There's no good relationship there. So we had follow-up on 723 patients, or 72%, which for a trauma study is extraordinary. 644 patients had 2-week follow-ups, and 441 patients had 2-month follow-ups. The original Atomic Guideline could be safely applied to 99.9% of the 1,000 children with splenic injury. And with the modifications for recurrent hypotension, the guideline really could have managed just all 100 of those, all 1,000 of those patients safely. 9% of the patients reached the algorithm endpoint for non-operative management, and only 24% of those patients could still be managed non-operatively. So it picked out 76% of those patients who were going to fail. Of the 8 patients who crossed over from stable to unstable, most of those did so for reasons other than their liver injury. And we saved about 540 hospital days on 300 patients, and basically the Atomic Guideline performed well. The study has generated a ton of publications for us. 6 of these have already been published, and they've all been published in the top journals, the top journal in pediatric surgery, the top journal in Journal of Trauma. And we have 6 more papers that have been presented and are in the process of being published or submitted for publication. So what happened to our patient? So his blood pressure, if you recall, had dropped from 70 to 50, and he had gotten a bunch of blood. We did not take him to CT scanner. We took him straight to the OR. Now, our OR is 200 yards away from our emergency department, at least for another few months. And that's a dangerous time. And his chest tube was placed on water seal. His pressure was 50 as we're leaving. We're hanging blood. We take a cooler blood products with us, and we got vasopressors in the bag just in case he arrests. We roll up in the operating room, and his blood pressure is 100, and his heart rate's down to 100, and he looks perfused for the first time since he's been here. And we place his chest tubes back to suction. He's got a constant air leak. The blood had finished en route. We had another 400 mils of blood from in that right chest tube. We got no imaging, and I've got a big bleed from his right chest, a positive fast, and I don't really know why this patient was in such a bad way. And plus, I've got a tension pneumothorax and a constant air leak, and maybe I've got lung problems. So we wait. And after 20 minutes, there's no more hypotension and no more blood products given. And at this point, we declared him a responder, and we left the OR without operating. This is the look you get when you leave the OR without operating. We went down to CT, and I'm not a big fan of the pan scan, but we pan scanned him. We scanned his brain, we scanned his C-spine, and this is what his lung looked like. And so for those of you who don't see this very often, this is his heart, that's his left lung, this is his right lung, and he's got a lot of contusion, probably a pretty good rent in that lung. When you look at the CT scan of his abdomen, if you're a surgeon at this point, you should be hiding your eyes in fear, because what we see here is an injury that goes from the outside of the liver all the way to the inferior vena cava. This is a retrohepatic cava injury. And there's blood around the cava right here. That's about as scary as it gets. So it's a grade 5 injury. And the PICU, his heart rate and blood pressure are reasonably stable. And day one, I've been awake all night, and at this point, Dr. Egan's taken over for me, and he had increased respiratory distress. He's got worsening subcutaneous emphysema. He's got a tension pneumothorax despite having a chest tube in. They put in 2 more, so he's got 4 chest tubes, and he's in a bad way at this point. We got to figure out what to do. Luckily, I was asleep by this time, and we with the chest tubes in, he's got massive air leaks, so we do a bronchoscopy to see if he's torn his bronchus. And the bronchoscopy was done at the bedside, and the bronchus wasn't torn. It was difficult due to hypoxia and a lot of blood in the airway, and Craig called me and said, hey, you want to come back in? I think we need to go take the lung out. And I woke up from my groggy sleep and came in, and Craig then took out the right lower lobe. Basically, and the reason that we did that is that the lung was torn all the way up to the bronchus, and when we went to go put stitches in it, the lung, it was like a blast effect, and the lung tissue wouldn't hold suture. So when we opened the chest, you could have died from the amount of sevoflurane that was in the room. And we did a formal lobectomy, and it looks like that. This is a rip all the way up. You can see that this lung right here is not normal. It's not like you cut it with a knife. It's just disintegrated there like a blast effect. So he got hit pretty hard. When he went back to the PICU doc said, this isn't the same patient that left. All of a sudden, this patient was easy to ventilate. He was hemodynamically stable. His course was, fairly complicated. He had some right-sided weakness, and neurocritical care saw him. He had some seizures and some possible ischemic injury, and he wasn't following commands. We were worried about that something bad was going on. His GCS was 3 to 11, and his initial head CT was normal. We got an MRI, and it showed diffuse axonal injury. His C-spine had some ligamentous injury, but nothing that needed operation. By day 5, he was extubated. Pain service was consulted, and he transferred to the floor on day 11. Psychology was consulted for coping, and he was discharged to a rehab 18 days later. Total of 6 units of PAC cells, 2 of FFP, and 2 of platelets. His TRIS, which is his probability of survival, was pretty low. That's him. So, managing multiply injured patients without imaging is hard. 40 mils per kilo or 4 units of blood is a good threshold for failure, but if you lose 600 mils into your chest or 1,000 mils in your chest, you can't really count that towards your solid organ injury. And luck beats skill, because if the OR had been closer, we probably would have been in the OR, and we probably would have lifted that liver up and made his bleed even worse. Thanks, appreciate it. Any questions? Nah. Maybe. The reality is that this type of studies, this type of work is extremely hard and extremely difficult. And the answer is maybe, but it's 10 centers is like herding cats. Even if you have good cooperative co-authors and other co-PIs, it's just really, really hard work. And that's 3 years of my life, effectively. So, but any other questions?
I think the case is awesome. It's a perfect example of what you do. The question I have is, you kind of understand 1, 2, 3 now, but we're still gray areas and corners of bodies about what's the threshold on which we're going to lose our opportunity to save a child because we're in a position we're not in.
Yep.
Any thoughts about, not that you're going to question, but any thoughts about how we progress to the next transition of how we use not
I am even more confident that 40 per kilo is an inherent threshold than I was when we started this study. When I started it, we had some evidence, but it wasn't great evidence, and now I'm thoroughly convinced that 40 per kilo basically lets you know who's going to stop bleeding and who's not. When you have concurrent injuries, it gets muddied. I have no reservations about taking this kid to the OR at 40 per kilo. I would do it again in a heartbeat. The fact that he had additional injuries that contributed to that, and he wasn't really bleeding 40 per kilo in his abdomen, we just got lucky on. But that, like I said, luck beats skill, and the 40 per kilo, it works. Great. Anything else? All right. Thanks, everybody.